This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Stroke and Cerebrovascular Diseases, published in 2026. It's titled Mechanical Thrombectomy and Decompressive Hemicraniectomy Trends for Acute Ischemic Stroke, a Nationwide Analysis.
This is a timely paper, Alara. In our field, we've seen a massive paradigm shift in how we manage acute ischemic stroke, specifically with the publication of the extended time trials like DAWN and DIFFUSE-3. These trials pushed our window for mechanical thrombectomy, or MT, out to 24 hours in selected patients. But the big question for us as surgeons has always been, how does this increase in endovascular intervention affect the need for decompressive hemicraniectomy, or DHC?
Exactly. Some hypothesize that as we performed more MT and achieved better reperfusion, the rate of malignant cerebral edema, and thus the need for DHC, would plummet. Others wondered if treating vulnerable late-window patients might actually increase the need for salvage surgery. This study used the national inpatient sample from 2016 to 2020 to give us some real-world data on these trends.
Let's dive into the numbers. What did the nationwide analysis show regarding the volume of these procedures?
The growth in mechanical thrombectomy is staggering. Between 2016 and 2020, the rate of MT among patients with acute ischemic stroke and large vessel occlusion, what we call LVO, increased from 4.0% to 9.2%. In terms of raw numbers, we went from about 20,810 MT procedures annually to over 52,000.
A more than twofold increase in just 4 years. That reflects the aggressive adoption of those extended window protocols. But what happened to the DHC rates during that same period?
Interestingly, the overall rate of decompressive hemicraniectomy remained remarkably stable. It was 0.9% in 2016 and 0.8% in 2020. Even though we are intervening endovascularly much more often, the proportion of stroke patients requiring a hemicraniectomy hasn't significantly shifted across the entire AIS LVO population.
That's a critical point for our residents to understand. Even with better reperfusion techniques, there is a subset of patients, either due to failed recanalization, reperfusion injury, or late presentation, who still progress to life-threatening edema. Now, did the study look at the DHC rate specifically within the group of patients who received mechanical thrombectomy?
It did, and this is where it gets nuanced. In the MT group, the rate of DHC actually showed a significant downward trend, moving from 3.4% in 2016 to 2.4% in 2020. Meanwhile, in the group that did not receive MT, the DHC rate stayed flat at 0.8%.
So, if you get the thrombectomy, your statistical likelihood of needing a follow-up hemicraniectomy is decreasing, likely due to better technical success in patient selection. But let's talk about the outcomes, because that's what truly matters in the OR. What did they find regarding mortality?
This was perhaps the most encouraging finding of the paper. While patients who require DHC naturally have higher mortality than the general stroke population, around 22.5% in this study, the in-hospital mortality for DHC patients actually decreased significantly over the study period. It dropped from 27.2% in 2016 to 18.2% in 2020.
A 9% absolute reduction in mortality for our most critical surgical stroke patients. That's significant. To what does the paper attribute that shift?
The authors suggest it could be a combination of factors: better perioperative critical care, more refined patient selection, and perhaps the protective effect of partial reperfusion in those who had MT prior to their DHC. They also noted that patients who underwent DHC were more likely to be younger and had fewer comorbidities compared to the non-surgical cohort.
Let's talk about the afterward. We know these are resource-intensive cases. What did the data show regarding hospital stay and disposition?
As expected, the DHC group had much longer lengths of stay, averaging about 16 days compared to just 5 days for the MT-only group. They also incurred significantly high hospital costs. In terms of discharge, routine discharge to home was much more common in the MT group. DHC patients were overwhelmingly transferred to skilled nursing facilities, long-term care, or required home health care.
It reinforces the fact that while we are saving more lives with DHC, the path to recovery remains long and arduous. For the residents listening, the takeaway here is that MT and DHC are not either-or procedures. They are complementary pieces of a modern stroke system.
Exactly. The paper concludes that while MT volume has surged following the extended time trials, the surgical footprint of stroke, the DHC, remains a stable and vital part of our practice, with improving survival rates that justify its continued use in malignant infarction.
Well summarized, Dr. Alara. It's a reminder that even in the age of high-tech endovascular catheters, the neurosurgeon's drill still has a definitive role in stroke care. That's all the time we have for today.
Thanks for joining us. We'll see you next time on the Neurosurgery Hub podcast.